Good morning, good afternoon. Shawn Stern, I'm here on the West Coast. I live in the Bay Area, but I cover the West Coast. I'm the territory manager. Chad Frederickson, he's our VP of Marketing and Finance. And Roger has been with the company the longest, about 8 years now. Started out as an engineer and helped develop and design the angel catheter. Now he's engineer / marketing. And we're here today to just kind of reintroduce the angel catheter for some of the folks that took part of the clinical study that UC San Diego was graciously to help us out with respects to gaining FDA approval. UC San Diego was part of one of 26 sites across the nation that participated in our study, and we just got approval last July from the FDA, and so now we're out scouring the states to target level 1 and level 2 trauma centers and raise awareness, and in the great hopes of being able to prevent PEs and be able to utilize a device that's now able to be placed bedside by trauma physicians and fellows and so forth, as opposed to taking these critically ill patients down to IR. So the angel catheter is a fully functioning triple lumen catheter, central line. And the neat thing is it has a permanently attached IVC filter. So it's a PE prevention device, a bridge therapy. Roger and Chad will be kind of passing it around really quick, just so we don't pull the filter. If you just pinch the white things together, you can pull and collapse the filter, and there's a stop symbol here. So then you can just kind of mess around with that, but don't try and pull it all the way out, because it takes. So that in a nutshell. Getting back on track. We see this as a bridge therapy for those subset of patients that are contraindicated to anticoagulants. Your TBI patients, pelvic long bone fracture, all those patients that are contraindicated to anticoagulants, being able to be placed now bedside by trauma physicians, critical care intensivists, fellows, once they come upon those subset of patients. Placing this bedside with only the need of a KUB to assess placement. So the physician will place this under their Seldinger technique, gain femoral access, using a .035 guide wire. It comes in the accessory kit that you guys purchased, and that's placed femorally in the groin under the guide wire. The landing zone is L1 to L4, or just anywhere just slightly above the bifurcation, right below the right renal. And how the physician is going to place this is essentially this is just more an overview. You guys, obviously don't have to memorize this, but they're going to pin the blue, and if you can watch, the catheter will be unsheathed. As I pull the white towards the blue, the catheter will then self-center and deploy. It's made of nitinol, nickel titanium, and so it'll self-center in the vena cava and expand. And now, at that time, the physician will ask to do a KUB. What the physician is looking for is there's RO markers at the tip here, and those will show up under the KUB. And that way you'll be able to determine if it's in the L1, L2 space, or anywhere in between the L1, L4 space. Once that's said and done, you'll see on the back of your pamphlet or little brochure there, we'll just use a biopatch, suture wing and overclamp, and a tegaderm to place over the top of it. And that just is, obviously from that point on, the catheter is in place, the IVC filter is in place, and now, as per your guys' hospital protocols for care and maintenance of a normal central line, that's how you would go and move about to maintaining the triple lumen. The big key factor here is this is placed in the ICU by trauma physicians, but when that patient is ready to start anticoagulants, it has to be removed in IR. IR will do a vena cavagram to assess clot burden, or if at that time, say during that window of 3 to 4 days that the filter was in place, if we caught a clot, so the filter will do, or the IR department will shoot a venocavegram, and they'll assess if the filter's full of clots or not, and then they will safely remove the filter at that time. So,
And if it is, what do they do? How do they do that?
good question. You want to take it off?
Yeah, there's a couple of options. With our clinical study, some of those patients could be starting anticoagulation, so they have anticoagulation for a few days. Some of them, if they're able to receive thrombolytic, you can get thrombolytic directly into the filter, which will break down the clot. And then in 5 cases, they put a traditional filter above, so gain access to the jugular vein, and then remove the device. And then if there's any thrombus that detaches, it will be captured by a traditional filter.
And that catch, I feel like clots are smaller than that.
So what we've in the industry, what folks, the fellow physicians have determined is, if you guys can all see, from the apex of the filter here to the first weld, is that what we classify as 25% filter volume. If it's 25, say if there's a clot that's less than 25% filter volume, that falls well within the range of safely able to remove the filter at that time. I guess that is like what they determine as not a significant clot that's going to truly cause harm to that patient. And so like Roger was saying, patient-dependent thrombolytics, TPA, lysine, anything of those sorts, however, anticoagulants, that physician at that time says, okay, we caught a significant clot, leave the filter in place, start anticoagulants to try and like have the body help break down the clot, or the agents kind of help break down that clot. And then maybe they assess it in a day or two and say, okay, well now it's safe to able to, then all they do is just do another venocavegram, they collapse the filter, and then the patient's ready to start anticoagulants. So it's very short term. One thing I want to circle back on in our clinical study, just for some other information, is obviously 26 sites across the nation, 163 patients, 1,100 catheter indwelling days, 0 catheter-related bloodstream infections. So we're very, proud about that, obviously, because most people ask, oh, it's a FEM line, are you worried about that? You're worried about this? So just to kind of reiterate that, that fact.
How long can you keep that catheter in for?
In our study, we had the shortest of 2 days and as long as 22 days. Our average length of stay in these patients was 7. If you look at, 7, yeah. So, look at like peak incidence of PE is day 2 in these critically ill patients, and in our study consisted of patients of ISS score of 26. So they were very, critically ill patients that were contraindicated for anticoagulants. A lot of times they were, 3, 4, 5 days going unprotected and at risk of a significant PE. Can you talk about the 129 venocavegrams? Okay, yeah. So that is essentially it. We gain, obviously, a lot of our knowledge from good questions. So the more questions you guys ask, or kind of the next steps, or anything of that sort. Actually, I want to circle back on one thing. From the nursing standpoint, when I come back and do another in-service for the rest or whatnot that I've missed, but say Dr. Smith places this under the Seldinger technique, the bandages are in place, I'm providing whoever my main contact will be here. There's these little stickers, and they're just caution stickers, really fluorescent, so that kind of stands out. And we'll just place it over the bandage saying, caution, this is an IVC filter, do not remove, because obviously if it's a line, middle of the night, folks want to remove it or whatnot. And then also there's this really bright fluorescent kind of patient card or placard that can go in the patient's file, and it says MRI compatible. It talks about the filter. You can probably mark on this placard, the filter was placed at skin incision 27 centimeters or 28, because what we want to do is, these patients are only sitting up or they can stand, but they're not moving around. They're bed bound, critically ill, and so they have an IVC filter in them, so they're not, it's in their groin. They're not going to moving them out around.
Have you ever had an accidentally, like, the patient takes it out?
Yes.
Or,
Thank you for bringing that up. That was my next part. What we had like 6 self-removals in the study, and that was before out of the 163. So the suture wing and overclamp goes here, biopatched and tegaderm. So the suture wing and overclamp is actually sutured to the skin. But we're finding that the physician needs to go ahead and also throw a suture through this part where the connector comes into play, just to suture that in place. And then for those subset of patients that were, those TBI patients tend to get really handsy, right? So you guys all know. So throwing like an ACE bandage or a stat lock or hospital, whatever you guys do for like central lines to keep them in place so they don't get removed. But let me rest assure you that this is made of nitinol, and it's all one piece of laser cut, no barbs. I mean, you can go ahead and if you think about your skin, it's not going to do any damage to the vena cava, and so you could go ahead and dispatch around and kind of give it,
The bigger concern would be if there's actual thrombus.
Yes, yeah. So we were fortunate at that time that those handful of patients, there was no significant clot in the filter where it got removed.
It's nothing to do, right?
So, yeah.
Sense the wrapping and everything.
Yeah. So, obviously, we've learned now that when we do our in-services to kind of try and cover everything. And you have me, I have my business cards out. Text me, call me. Hey, Shawn, we're about to do one. My main goal is, we just launched Cedars-Sinai. I was just over at Scripps this morning. They're very interested in doing this. I'm going to be here a ton. So hopefully you guys get to see a lot of me, and that way my main focus is to successfully implement this into your guys' hospital and to your protocols for this subset of patients that we're talking about that have currently been in the past unprotected by unprotected or at risk of PE. Yeah.
I see it does say it's a power injection. Is that a non-toxic power injection?
Yeah.
It doesn't say it on the label, so I was looking at.
Oh, because these are like first generation. The ones that you have that you guys received, the 6, it actually says 17 gauge power injection, 10 power injection 5 distal port, or and then the other one is the blue, which is the medial, that says no power injection. Yeah. So it's fully functioning triple lumen, right? But it's slightly bigger. It's a 9 French as opposed to what is your guys' central lines, like 7 or so? Yeah. So so it's a little bit bigger, and so you have the box with the angel catheter. You have the accessory kit, which contains everything you need to place the device, other than obviously lidocaine, no medication or anything in there, but just everything else. Yes, ma'am.
Do they monitor any hemodynamic CVP port off of that if it's a central catheter?
Yep, you could still do blood sampling, all the CVP monitoring, right? All the good stuff. Yeah.
So your flush port. And
Yeah.
Was there a point where you were taking it down every few hours? I feel like I heard that before, but no. Okay. So we've never used it here, right?
For the clinical study, you guys actually placed, I think you guys placed 6 or 7.
Oh, really?
Yeah, Dr. Doucette and
I remember Terry like having it.
yeah, Terry White.
Curry.
Curry.
Yeah.
There's so many people I know. It's like, yeah. Yes. What else? Is it? Yeah.
Is it just one size for the very short or the very tall?
Absolutely. It's one size. That's why you have that good landing zone.
You don't get
You have the landing zone from L1, L2 to L4, or just even above the bifurcation. So you have a good, space to accommodate, all different heights, sizes of patients, and so forth. Yeah.
And we deploy the filter before shooting the X-ray.
Yes. So you would do the.
So we actually recommend a couple things.
Yeah. Go ahead.
So for physicians, do you guys have the digital X-ray?
We do.
Yeah. So then when in service positions, we recommend they do a KUB with the guide wire just to make sure it's on the right side of the patient. And if you can, do another X-ray once you put in the device, just to make sure that you've got the tip where you want it to be, and then when you unsheath it, you do the third one, just to make sure the device is fully deployed.
So you just have one link, though. So
Yeah.
it's-
Yes.
Recently got some pretty big.
Yeah. I think we did it on a 6'7" person in the study, and it worked.
Okay.
So yeah,
So, sorry, you want three x-rays?
If it is possible.
that's like obviously in a perfect world.
Right.
Yeah, I mean,
But if not, after deployment,
yeah,
for sure do an X-ray.
yeah. Yeah, we just has to be below the right renal, so, you know, obviously being able to make sure that landing zone is appropriate. Sorry.
So before we have catheters.
Yeah.
So there's,
Yes.
we have them secured because Dr. just has not gotten all our little things ready for us to launch it. So these are questions we'll ask him because I think it really should be our physician's directive. How many x-rays? or
Yeah,
that process.
absolutely. I completely agree. Yeah.
Does MRI know about this product? That's compatible? You guys said it's compatible.
It's MRI compatible, yes, and it'll be obviously all the information on the patient card. As far as do I know or have I spoken with your guys' MRI department? No, not yet. But if it need be, I'm happy to speak with
I
them.
didn't know
Heavy on
that.
policy.
Okay, yeah, something that I would love to get in front of.
Well, I
Yeah.
think we should go through Dr. Doucette as well. He knows the departments who need to
Yeah.
be notified.
Yeah.
And again, we're sitting on this until we have clarity on our processes and nurse
Yeah.
staff, what we will be monitoring physicians for and whatever departments.
Yeah, absolutely. Thank you. What other questions?
Is alteplase not indicated with this? And what is that?
So they can receive TPA, it's patient dependent, but you can administer through our device.
So if there's no other questions, you know, I look forward to coming back and starting a relationship and working with you guys. Yeah, I really look forward to, you know, helping out these patients and preventing PEs. Yeah.
Thank you.
Thank you.